Hi, Davidson Fellows Committee. My name is Shreya Sibal, and I'm a current junior at Tenafly High School in Northern New Jersey, and I'm grateful for the opportunity to present my research to you all today. My interest in oncological research began when my grandfather was diagnosed with stage 2 esophageal cancer. Although he was in India and I was thousands of miles away here in the US, over our FaceTime calls, I could see how profoundly the cancer had impacted his way of life. He underwent chemotherapy and radiation, which helped stop the cancer from spreading, but these treatments were also very damaging on his body and left him in a lot of pain. Seeing cancer impact someone so close to me made me interested in the disease and specifically interested in finding effective but minimally invasive treatments. I began interning in a research lab that focused on studying the molecular mechanisms of prostate cancer with a specific focus in developing and testing effective therapies. Prostate cancer is the second leading cause of cancer-related deaths in men. African American men have the highest risk of developing prostate cancer due to a culmination of socioeconomic and genetic factors. Prostate cancer growth in its earlier stages is primarily driven by the androgen receptor signaling axis. When androgen binds to its receptor, it induces a conformational change and allows for the translation of mutated oncogenes. African American men are noted to have increased levels of mutations in the MYC gene as well as androgen receptor variants, resulting in resistance to standard monotherapies. The two main drugs that are considered standards of care that were approved by the FDA but still undergo various testing in the lab and clinical settings are darolutamide and leuprolide. Darolutamide works by blocking androgen binding to its receptor, thereby preventing the complex from causing cancer growth. Leuprolide works by systemically lowering the amount of androgen in the body. In theory, these drugs should work perfectly. However, unfortunately for us, prostate cancer is clever and knows how to evade these treatments. This happens when cancer gains the ability to bypass androgen inhibition, thereby fueling cell proliferation via other signaling pathways. So, when I started my research as a preliminary jumping off point, I wanted to determine the IC50, 50% killing, of leuprolide and darolutamide by itself and in combination. I decided to use the LNCaP cell line specifically as the cell line was derived from cancerous lymph nodes of a human patient and has been cited for its ability to preserve majority of the in vivo characteristics of the disease. This cell line is also androgen dependent, providing a basis for me to compare androgen dependent versus androgen independent cell lines in terms of efficacy of drug dosages. So I plated LNCaP cells in a 96 well microplate and allowed them to grow until they reached 70% confluency. I set up my experimental design in a way to accommodate a wide range of drug doses, ranging from 0.1 nanomolars to 10 micromolars. I incubated the cells, and at 48 hours, I conducted a cell T-to-go assay, which measures cell viability through ATP content. I found that the IC50, which is of combination therapy, was less than half of darolutamide or leuprolide at 0.1 micromolars. I also used the true-tally method to determine the combination index, which was less than 1, showing synergistic effects of drug combination. I decided I wanted to test these similar drug doses in an advanced model. A few years ago, my mentor, along with his colleague, created a clone cell line that was resistant to enzalutamide, an anti-androgen in the same subsect of darolutamide. They did this by culturing LNCaP cells in enzalutamide over a period of 3 to 4 months, and then specifically selecting those that could withstand concentrations of enzalutamide 5 times higher than its physiological levels. This cell line would serve as an indispensable tool for me, as the cell line almost exactly mimicked the mechanisms of which patients become resistant to drugs. They also conducted RNA sequencing and determined that the cell line was expressed with both wild-type AR and ARV7, a variant that many patients, especially in the African American population, developed. This information was instrumental for my studies later on. So I decided to use a cell line to test these dosages. I was also curious to test pembrolizumab, which is an immune checkpoint inhibitor, and I selected a dosage of 5 micromolars. So to test pembrolizumab accurately, I had to employ PBMCs, which are peripheral blood mononuclear cells. These cells are basically immune cells that, by adding them to my cell culture, would more accurately depict a patient's immune portfolio and profile in their body. So processing these blood samples involved using a density gradient centrifugation to separate the cells from its platelets and plasma, as well as purification. And so after 48 hours of the drug treatment and PBMC treatment at a 1-to-1 ratio, I conducted the WST1 assay and found no statistical significance between treatment groups. While confused at first, after reading more papers online and discussing with my mentor, we discovered that the reason that there was no effect of pembrolizumab was most likely due to prostate cancer not being a very immune active cancer, by which the cancer cells did not have PD-1, rendering the PD-L1 mechanism of drug unachievable. Additionally, we determined that the CLA cell lines were resistant to darolutamide because it had bypassed androgen signaling altogether. She told me about glucocorticoid receptor signaling. Previous studies have shown crosstalk between the two pathways, in which the GR signaling axis allows cells to bypass AR blockade. This is exactly what could explain what was going on with our results. So I decided to test this by testing the efficacy of glucocorticoid receptor antagonist PT150 along with its dimer PT157. This drug was originally developed to treat neuropsychiatric disorders such as depression, but showed promising capabilities here. My lab members had already done a previous study in LNCaP models and came up with IC50 values. I wanted to compare these same IC50 values in CLA. So after growing CLA cells, I treated them with these drug dosages and lysed cells to conduct Western blots. I conducted Western blots of select antibodies that were relevant to prostate cancer disease mechanisms such as AR, ARV7, PSMA, MICAP, PMAP, and more, and AKX 3.1. I found that PMAPK, which is a signaling protein that regulates cell cycle progression, was diminished in PT150 and PT157 and even further in combination, showing efficacy. Additionally, ANKX 3.1 was also greatly diminished in combination therapies, showing promising results in the fact that they were able to reduce the expression of key tumor markers. The interdisciplinary nature of my work was really exciting. Whereas standard therapies of Lupro and Daro hadn't worked, glucocorticoid receptors, which were drugs that weren't developed in any relation to the treatment of prostate cancer, had extreme potential and had shown success in my study. This research could also have profound implications for other cancers as well. I'm working to further develop my research by understanding and evaluating the full pharmacokinetic effects of the glucocorticoid receptor antagonists on the tumor profiles. Thank you for listening to my presentation.